Good morning, everybody. This is Dr. N.R. Vignesh, Associate Professor of Dermatology, Sree Balaji Medical College, Krompet, Chennai. So today's topic will be about dermatophytosis. The specific learning objective of this topic is to identify the various types of dermatophytosis, to what are the investigations which are required for dermatophytosis and the management for dermatophytosis. Dermatophytosis is the superficial keratinophilic fungal infection of the skin, and commonly we can classify fungal infections broadly into superficial fungal infections, subcutaneous fungal infections, and systemic or deep fungal infections. The commonest example for the superficial fungal infection is pityriasis versicolor, piedra, as well as dermatophytosis. And for subcutaneous mycosis, we can classical example is mycetoma and sporotrichosis. And the systemic fungal infections or the deep fungal infections are usually opportunistic fungal infections, which is seen in the immunocompromised patients. Classical example will be histoplasmosis and cryptococcosis. Okay, and dermatophytosis is a very common fungal infection which is seen in the coastal areas like hot and humid tropical climates of the world, and it affects almost 40% of the world's population. And dermatophytes usually affect your skin, hair, and nail. The other names which commonly which we use are tinea. So that is the commonest term which we use, tinea, and for the patients they usually go by the term ringworm. Okay, so these are the two commonest names which are used for the dermatophytosis. And coming on to the classification of dermatophytosis usually it is caused by the three genera: Trichophyton, Microsporum, and Epidermophyton. And among this, all these will have different species of dermatophyte. For example, Trichophyton rubrum, Trichophyton mentagrophytes, Trichophyton schonleni, Trichophyton tonsurans, Trichophyton violaceum. And in Microsporum, we have Odoni and Canis, Equinum, and Gypsium. And in Epidermophyton flocosum. This is based on the morphological classification of tinea. And we also have another thing which is called as ecological classification. That is, depending on the source where you are getting, we can classify into three: anthropophilic, zoophilic, and geophilic. Anthropophilic is human to human transmission, and zoophilic is which acquires from the animals, and geophilic is Microsporum geophilic, which is acquired from the soil as well as from the other decayed wood. Okay, classical examples for anthropophilic infections are Trichophyton tonsurans, Trichophyton violaceum, and for zoophilic it is Microsporum canis and Microsporum equinum, and for classical example of geophilic fungus is Microsporum gypsium. And why do we classify this as anthropophilic and zoophilic and geophilic? Is anthropophilic infections are usually non-inflammatory, whereas your zoophilic and geophilic fungal infections are quite inflamed. Okay, they cause inflammatory skin lesions. And another mode of classification is clinical classification. Depending on the body surface area, body area which is involved, we can classify them as tinea capitis, which involves the scalp hair, which is commonly seen in children, and tinea barbae, which affects the beard region of the males. Tinea faciae, which involves is a dermatophyte infection of the non-hairy region of the face. Tinea corporis, which involves the glabrous region of the body. Tinea manuum, which involves your palms. Tinea pedis, which involves your soles. Tinea unguivum is dermatophytic infection of the nails. So what are the risk factors to acquire dermatophytosis? The first and foremost is the hot and humid climate, because dermatophytosis is present all over the world, but is very, very common in tropical areas like India as well as the Southeast Asia and Africa. And another thing is malnutrition, Poor hygiene, that is also one of the main factor which aids in the acquiring of dermatophytosis. And occlusive clothes and footwear, obesity, diabetes, immunocompromised status, and coexistence with other bacterial infections, contact with pets, and other atopic other risk factors are atopic individuals and Cushing syndrome. So these are the few risk factors. Among these risk factors, hot and humid climate, malnutrition, and poor personal hygiene. So these are the main risk factors for acquiring dermatophytosis. Coming to the pathogenesis of dermatophytosis, usually dermatophytosis is acquired by the transmission of the arthrospores. So arthrospores, once a person is infected with these fungus, it undergoes 4 stages. Stage of incubation, wherein it is the period where the fungus undergoes a period of enlargement, and it is promoted by trauma, maceration, and increased hydration of the skin, followed by a period of enlargement and a period of refractory period, and then followed by involution. Involution either by spontaneous involution based on the host immune response, mostly by cell-mediated immunity, it can undergo involution, or else if the patient is taking treatment, it can undergo involution. Coming on to the clinical features of dermatophytosis. So the first type what we are going to learn about is tinea corporis. As I mentioned already, tinea corporis is a ringworm fungal infection of the glabrous skin. Here the terminal hairs in the affected skin may be affected, and it includes the lesions which are present in the trunk mainly. So trunk, and you have to trunk and limbs except the scalp, groin, palms, and soles. So the most common fungus which causes dermatophyte which causes your tinea corporis is Trichophyton rubrum, Microsporum canis, or Trichophyton mentagrophytes. So the clinical features of tinea corporis is once that period of invasion has acquired, there is approximately incubation period we can tell 1 to 3 weeks. So what happens is the patient will present with itching. Itching is a predominant symptom of tinea. Any sort of all dermatophyte fungal infection except tinea capitis, they present with intense itching. Itching is the commonest symptom of dermatophytosis. So what the patient will develop is, the patient will develop itching, and then the lesions will start developing. The classical lesions here, what we describe here is an annular lesion with an advancing border with a central clearing. So this is how we describe a typical lesion of a tinea. So a typical tinea will be having an erythematous advancing border which can be studded with pustules or papules, with the central clearing will be there, and in the border there will be scaling can be seen because of the increased epidermal turnover. And then you can also see various types of other lesions, like it can be polycyclic, it can be scaly, or it can be vesicular, all with a central clearing will be there. And and the pruritus also will be quite severe, and the degree of inflammation depends on the species. As I told you, anthropophilic won't have that much of inflammation, whereas zoophilic and geophilic organisms will present with lot of inflammation. So this is a patient picture of dermatophytosis, which is tinea corporis. Here you can appreciate the advancing border here. You can see the advancing border and a bit of central clearing is observed here. So this is a case of tinea corporis. So tinea corporis has different variants. Among the commonest type what we are seeing clinically is tinea pseudoimbricata. Otherwise we call it as tinea incognito, which is nothing but tinea which is modified by topical or systemic steroid usage. Because patients nowadays usually go for, it's a common over-the-counter treatment. They will be they start applying all these topical steroids which are available over the counter. So what will happen after applying topical steroid is the inflammation will start coming down, and the patient will be devoid of itching. But what that fungus will do is it will start spreading outside. So initially the patient will be having a small lesion. After applying this steroid combination treatment, the itching will come down, but the lesions start expanding, and the lesions will develop ring within a ring appearance, and atrophy and telangiectasis and other side effects of steroids can also be seen with the patients who have applied topical corticosteroid. So the next fungal infection is tinea cruris, which is nothing but jock itch, otherwise called as ringworm of the groin, Dobie itch, or jock itch. So this is most commonly seen in the males, and because of the wearing of the occlusive clothes over there, and due to increased sweating. So that causative organisms are Trichophyton rubrum, Trichophyton interdigitale, and Epidermophyton floccosum. And the clinical feature is the same as mentioned for tinea corporis. Here also you will be having an advancing border will be there, erythematous, and followed by a central clearing. And this can also extend up to the buttock region, perianal region also it can expand up to it. So this is a clinical image of the tinea cruris. As you can appreciate here, the advancing borders and little bit of central clearing which are involving the groin region. Then third fungal infection is tinea capitis. This is a peculiar fungal infection because tinea capitis is a dermatophyte infection of the scalp hair follicles, and it is more commonly seen in the children, prepubertal children. This is very rare in the adults. This is the most common fungal infection of the children, of the dermatophytosis, which occurs in the children in the prepubertal region. Why prepubertal is, this is the age where your sebum secretion of the body is not present, because sebum will start secreting only when the patient undergoes puberty. So prepubertal children, they will be devoid of sebum because the sebum has it has fungi static property. So since the patients are devoid of the sebum, so the fungal infection is quite common in this age group. Common organisms are Epidermophyton flocosum, Trichophyton concentricum, and Trichophyton violaceum. Here the another thing is, this fungus first it starts on the scalp, and then it penetrates into the side of the hair follicle till it reaches a zone which is called as an Adamson's fringe. That is the region where the keratinization begins. So this infection is seen above the Adamson's fringe. So here we have two types of tinea capitis, non-inflammatory type and inflammatory type. Non-inflammatory type is of two types, grey patch type and black dot type, and inflammatory tinea capitis of two types, Chirion and Favus. The grey patch type is commonly caused by Microsporum odoni, which presents with a circular scaly patches with partial hair loss with dull broken hair. And this is the Microsporum odoni is responsible for the epidemics of tinea in the school going children. Another type is black dot. Black dot type is nothing but it is the same. What happens is, another thing what I would like to mention here is, in the tinea capitis, you have two types of invasion of the hair follicle. One will be ectothrix type, another is endothrix type. Ectothrix type is the fungal spores will be present, fungal spores and hyphae will be present on the surface of the shaft. Whereas in endothrix type, the fungus invades the hair and it's present inside the hair, including the medulla and the cortex. So what will happen in the black dot type is, it is mostly caused by endothrix organisms, Trichophyton tonsurans, Violaceum, and Sudanese. So what these organisms will do is, they will cause an endothrix type of fungal infection, and the scalp hair becomes brittle and it starts breaking at the level of the scalp surface. That is why you are going to see the numerous black dots on the surface. Then third variety is the inflammatory type, which is the Chirion. Chirion is nothing but it is an inflamed, boggy, tender swelling which is studded with the pustules. What is the importance of this Chirion type is, once it resolves, it usually resolves with scarring. So that is the main main complication which is seen with the inflammatory tinea. Another example of inflammatory type is a Favus. Favus, which is characterized by the yellowish cup-shaped crusting, which is called as a scutula, and which has a mousy odor associated with it, and it is caused by Trichophyton schonleni. So this is a clinical picture of the patient who has tinea capitis. One is of the grey patch type and another is of the Chirion type. Here you can observe the boggy swelling which is present with numerous pustules. The fungal infection is tinea barbae. So tinea barbae otherwise called as barber's itch or tinea psychosis. So it is a dermatophytosis of the hair follicles of the beard and mustache area. It's quite less, and the name itself with the barber's itch, it is usually acquired from the barbers. So the clinical features are, it is classified into four types: psychosiform type, Chirion type, non-inflammatory type, and blepharoceliosis type. Another variant of tinea is tinea faciae. As I've already told you, tinea faciae is dermatophytic infection of the non-hairy region of the face. This is the most common fungal infection which can occur in almost all the age groups. Most common organisms is Trichophyton rubrum, Mentagrophytes, Microsporum canis, Gypsium, and Trichophyton violaceum. Clinical feature here is the patient presents as usual with itching, burning, and photosensitivity will be there. Pinna is commonly involved, and here also you will be appreciating the erythematous annular plaque with central clearing and a little bit of scaling which is appreciated in the periphery of the lesion. And the atypical manifestations can also be seen with erythematous plaques with vesiculopustules, and broad borders can also be noted. Another variant is tinea pedis. Next fungal infection, tinea pedis. It's otherwise called as athlete's foot. It is the infection of the soles of the feet and the interdigital spaces, and it is the most common organism which causes is a Trichophyton rubrum, interdigitale, and flocosum. Here we have four types of tinea pedis: interdigital type, chronic hyperkeratotic or moccasin type, and vesicular type, and acute ulcerative type. So these are the four types of tinea pedis. Here you can appreciate that interdigital type, and this is the chronic hyperkeratotic type of tinea pedis. Next fungal infection is Tinea manuum. Tinea manuum is dermatophytosis of the palm of skin. One thing what I would like to mention here is Tinea pedis and manuum can coexist together, which can be a part of the 2 feet 1 hand syndrome. Like two of the soles can be involved and one hand can be involved. That is that we term it as 2 feet 1 hand syndrome. And the most common organisms are Trichophyton rubrum, Antagrophytes, and Flocosum. So here the main predisposing factor is sweating, hyperhidrosis, mainly of the palmoplantar hyperhidrosis can be associated, manual labor, poor peripheral circulation, and occupation. Here also you can classify them as non-inflammatory squamous type, inflammatory vesicular, dyshydrotic, or eczematous type, and other variants are also present. The most commonest presentation is dyshydrotic type and non-inflammatory type. So this is a clinical picture of the tinea manuum. Here you can see the hyperkeratotic, well-defined scaly plaque which is involving the palms. And you can also appreciate that lesion is extending even up to the interdigital web spaces. And another fungal infection is tinea unguivum, which is nothing but dermatophytic infection of the nail, and it is more commonly seen in men as well as in housewives who have constant contact with the water, who do household work. Toenails are also commonly affected. Predisposing factor for a dermatophytic infection of the nail are poor peripheral circulation, trauma, diabetes mellitus, HIV, old age, smoking, hyperhidrosis, and occupation. So in fungal infection of the nail is of four types: distal lateral subungual onychomycosis, proximal subungual onychomycosis, superficial white onychomycosis, endonyx, and total dystrophic type. In all the four types, distal lateral subungual onychomycosis is the most common fungal infection of the nail which is seen. And if the patient has proximal subungual onychomycosis and superficial white onychomycosis, they are early indicator of HIV infection. So these are about the common clinical features of the various dermatophytosis. So coming on to the investigation, dermatophytosis is usually a clinical diagnosis. There are not much investigations which are required, but in case of any doubts, we can order some investigations. Woods lamp, these are available only in medical college setting. Normally in outside clinics and hospitals, we do not go for Woods lamp examination. It's mostly of academic interest. And another investigation is potassium hydroxide, KOH mount. And the third is we'll go for fungal culture, and another thing is we can even order for biopsy, which is very rarely required. So the Woods lamp examination is by using a Woods lamp, which is nothing but it consists of a barium silicate filter and which uses a 365 nanometer UV light. So using that, what we are going to do is we are going to look for the lesions and look for the fluorescence which are associated. Usually in Woods lamp examination for tinea, usually the microsporum species and Trichophyton schonlevi will fluoresce because of the presence of pteridine pigment which is present in the cell wall. And usually the color will be of apple green fluorescence or a little bit brightish green fluorescence can be appreciated under a Woods lamp. So how we are going to collect the specimen for the KOH examination is we are going to scrape the lesions, and also you can pluck the hair, and also you can go for a nail clipping from the onychomycosis, that is nothing but tinea unguivum is there, we can go for nail clipping from the active margins of the lesions. So the main thing is for other scraping which is done from the skin, direct examination is 10% KOH. Within 5 or 10 minutes you can observe under the microscope, you will be appreciating the thin septate branching hyphae can be appreciated. Whereas for the hair as well as for the nails, the specimen has to be kept in the 40% KOH for half an hour or to 1 hour for dissolution of the keratin, and then you can observe under the microscope. So this is what you are going to see under a KOH mount. You will be seeing branching septate hyaline hyphae which show arthrospores. Fungal culture we usually do with Sabros dextrose agar and dermatophyte test medium. Skin biopsy, which is rarely indicated, which we do not go for routine cases of tinea. What you can see is neutrophils can be observed and numerous fungal filaments which can be present in the stratum corneum. between upper orthokeratosis and lower parakeratosis associated with spongiosis and papillary dermal edema. Coming on to the management of dermatophytosis, management is first is general measures. This is very, very important because the treatment is not just treatment with just drugs is not required. The patient has to follow strict general measures. Yeah, they have to avoid soaps, towels, combs, and clothes and bedding, and avoid occlusive footwear, and their clothes has to be washed separately and dried up in the sunlight. The patient have to take bath twice a day. Nails has to be trimmed properly and avoid contacts with the pets, and proper counseling has to be done regarding the proper treatment of other family members who are affected with this disease, and they have to adhere to the treatment and avoid steroid abuse. So generally we usually give two types of therapy. One is topical therapy, another is systemic therapy. Topical therapy, usually we give topical azoles. So a topical azole example is topical ketoconazole, topical miconazole, topical luliconazole, and sertaconazole and oxyconazole. And also terbinafine is also available as topical creams that can be applied. And another is systemic therapy. Systemic therapy for antifungals, usually we go for azoles as well as allylamine derivatives. Common example is terbinafine. For azoles we have fluconazole, itraconazole, and allylamine derivative is terbinafine, and another is heterocyclic benzofuran, which is griseofulvin. So the main thing what that this thing is, we have to go for the proper duration of the treatment. Usually fungal infections nowadays they resolve in about 4 to 8 weeks. So the textbooks usually give 2 to 4 weeks, which is not followed in the clinical settings. So usually it requires 4 to 8 weeks of therapy. And usually topical, for tinea corporis and tinea faciae and tinea cruris, topical therapy are more than sufficient if it is quite limited. If the lesions are numerous and if it involves almost 30 to 40%, if it's extending more than the body surface area, then we can go for a systemic therapy. Systemic therapy, as I mentioned, with these drugs can be given for 4 to 8 weeks for the proper resolution. Okay, so the dosage of itraconazole is 200 milligram daily or 100 milligram 2 times a day for 4 to 8 weeks, and terbinafine 250 milligram OD or 250 milligram BD for 4 to 8 weeks can be given. Fluconazole 3 to 6 mg per kg, either it's given as 150 milligram bi-weekly, or some will give 150 milligram thrice weekly, or sometimes 50 milligram daily can also be given for 4 to 8 weeks, that can be given. And another thing is griseofulvin. Griseofulvin dosage is 500 milligram to 750 milligram, or even up to 1 gram can be given. The problem with griseofulvin is it requires a little bit prolonged treatment. So like 4 to 8 weeks cannot be sufficient. Even sometimes it can last still more longer. For nail infections, usually we limit with terbinafine and itraconazole. For nails, griseofulvin will not work much. And another thing is, for tinea capitis, griseofulvin is the drug of choice in the children without any side effects. And for tinea capitis, griseofulvin has to be given for a period of 8 to 12 weeks. So other drugs which can be used for tinea capitis are itraconazole as well as terbinafine can also be used. To summarize, dermatophytosis is a superficial keratinophilic fungal infection of the skin. Based on the body surfaces involved, we have classified the dermatophytosis as tinea capitis if it involves the scalp hair, tinea faciae if it involves the non-hairy region of the face, and tinea barbae when it involves the beard region of the beard, and then tinea corporis if it involves the glabrous region of the body, tinea cruris if it involves the groin, tinea manuum if it involves the palms, and tinea pedis if it involves the soles. And we have seen what are the investigations which have to be done for dermatophytosis, starting from Wood's lamp and then KOH examination, and if required fungal culture. And the management of dermatophytosis, as you have mentioned, it consists mainly of topical therapy and systemic therapy, both in combination. And to summarize, so dermatophytosis is a dermatophytosis is a common fungal infection which has to be identified properly, and based on the body surface involved, we can treat with topical therapy as well as systemic therapy. Kindly do not use systemic or topical steroids in the management of dermatophytosis. And one more thing is you have to advise the patient regarding the compliance of the treatment as well as the proper hygiene for the patient to help in the clearance of the dermatophytosis. Thank you.